Hello, everyone, and welcome to today's NGA webinar on equitable distribution and uptake of remedies and resources pertaining to the COVID-19 pandemic. My name is Veronica Charles, and I am the Director of Policy and Advocacy at the American Society of Consultant Pharmacists. I will be moderating today's webinar, and the webinar is being hosted by the National Governors Association in collaboration with the American Bar Association as a part of a 4-part webinar series on equity and policy preparedness during public health emergencies. This work is funded by a cooperative agreement between the NGA and the U.S. Centers for Disease Control and Prevention. The presentation content does not necessarily represent the views of NGA or CDC, and the information presented should not be construed as legal advice or guidance. During today's webinar, we will delve into the distribution and uptake of remedies and resources during public health emergencies, specifically the one that we're living through right now. Our speakers will discuss how to ensure that the needs of the communities disproportionately affected by COVID-19, such as communities of color, are being met. We will also examine how historical racism in medical research influences the uptake of prevention measures in racial and ethnic minority communities and how those can be addressed. And we will also discuss the strategies to support uptake by these communities in the current COVID-19 context. Finally, we will explore the legal, policy, and ethical considerations for the distribution and uptake of remedies and resources in the context of the ongoing public health crisis. So a few quick housekeeping items. Oh, I keep going forward, but I want to go back. So a few quick housekeeping items before we do our speaker introductions is that this webinar is being recorded. The recording will be posted on NGA's website at nga.org/webinars, and everyone has been muted currently to minimize background noise. We are holding all questions until the end of the webinar, but should you have questions at any point in time, you may feel free to put it in the chat box, and you may also select the mute or unmute at the bottom of the screen when we get to the question and answer portion. If you experience technical difficulties, you can contact Claudia Bonilla via the chat or at cbonilla@nga.org. Next slide carefully. Great. So we will have a fantastic group of speakers today who have agreed to join the call and share their perspectives on this critical topic. In the order that we will be hearing from them today, we have Dr. Gary Puckren, President and CEO of the National Minority Quality Forum. Then we will hear from Dr. Angela Riley, who is a clinical pharmacist, as well as Binghamton City Councilwoman and Speaker of the House for the National Pharmaceutical Association. And lastly, we will hear from Andy Pickett, the Director of the Bureau of Public Health Preparedness at Pennsylvania Department of Health. We will follow the presentations with the question and answer portion that we previously discussed. I want to thank all of our speakers for being with us today. I am so excited to hear from these experts, and I'm sure you are all as well. So we will get started. To begin, we have Dr. Gary Puckren with the National Minority Quality Forum. Dr. Puckren is the President and Chief Executive Officer of NMQF. In 1998, he founded NMQF's predecessor program, the National Minority Health Month Foundation, to help communities and policymakers eliminate the disproportionate burden of premature death and preventable illness in special populations through the use of evidence-based, data-driven initiatives. Dr. Puckren has built NMQF's capacity to house vital statistics and other information, including demographic, environmental, claims, prescription, laboratory, hospital, clinical data in a centralized data warehouse. So I know that my organization has benefited from all of his research. It's been really great to see what he has been working on. He has also led the development of NMQF's health indexes to measure and forecast health status in very small geographic areas. And his database can evaluate the impact of specific interventions, monitor changes in health outcomes, provide information and analysis regarding the health of ethnic and racial minorities. So Gary was awarded his doctorate from Brown University, graduating Phi Beta Kappa. With that, I'm going to allow Dr. Puckren to take it away.
Veronica, thank you so much. And I want to thank the staff at the National Governors Association for the opportunity to present this today. I want to talk to you about using big data to promote minority health, particularly in this era of the pandemic. So first, for those who don't know us, I'm going to talk a little bit about the National Minority Quality Forum. I want to talk to you about work we're doing on flu vaccines in minority communities. Then we're going to take a look at predicting COVID by zip code. And then finally talk to you about a study that we're undertaking looking at minority and rural communities with the virus. So first, the National Minority Quality Forum, we were founded in 1998. We are a Washington-based research and education organization whose mission is to reduce patient risk by assuring optimal care. Most of our work has been around developing health data. We've been collecting health data for about 20 years. We have a database of over 5 billion patient records, which we use to look at disease prevalence and cost and outcomes for demographic populations at the zip code level, and then we can aggregate up to higher geography. Typically what we do with that data is we put it into a geographical information system because it's an easier way to distribute the information than providing a SAS spreadsheet or an Excel spreadsheet. And this way we're able to hone in and show where disease prevalence are down at the community level. So we all know that COVID has disproportionately impacted minority populations in many cities like Chicago and New York City. African Americans and Latino populations have had substantially higher mortality rates, higher hospitalization rates. Lots of theories about why those outcomes. They range from social determinants of health to comorbid conditions like diabetes and asthma. I've heard reports that vitamin D deficiencies are contributing to it. But at the end of the day, the science is still not clear on why we're seeing those disproportionate outcomes. And I'm going to talk to you later on about some studies that we're doing to try to get a better handle on why that is. But first, I want to talk to you about flu vaccine. And the reason why I want to talk to you about flu is because as we think about a vaccine for the COVID virus, we have to address the issue that historically minority populations, at least when you look at vaccine rates, have lagged behind. So as you can see from the data, looking at adults above the age of 18, only 41% of Blacks are getting vaccinated. About 38% of Hispanics are being vaccinated. And these numbers have been around forever. Even in a program like Medicare fee-for-service, we see differentials between minority populations in geographical areas. And we also see that minorities don't get the high dose. For those who don't know about the high dose, it is used particularly in seniors because of immune senescence. They need a stronger vaccine, and what we see is disproportionate outcomes for the vaccines in minority populations. So minority populations are 30%, that is Blacks, are 30% less likely to be vaccinated in the Medicare program, and it's about 34% for the Hispanic population. All of that has consequences. So when you look at hospitalization rates from the flu vaccine, some numbers that were just released by CDC, African Americans have a rate of 68 per 100,000 hospitalizations for the flu. And as you can see for whites, it's about 38 per 100,000. And so that failure to administer the vaccine means that it translates into higher hospitalization rates for minority populations. So in our work, we've been looking at mapping, and here I'm showing you a map. This is 2016-17 data looking at flu vaccination rates by zip code for African Americans. You see by that yellow, those yellow means That's somewhere under 11% of the population in that zip code, Medicare fee-for-service beneficiaries are getting the vaccine. And an important thing to note here in this, what this map is showing you, there are 38,000 zip codes in the country where people live. 70% of African Americans live in 2,500 zip codes, and a lot of those zip codes are in the southeastern part of the United States. So long before the COVID virus, we have been looking at these flu vaccination rates, and we pulled together an expert panel to think about how can we improve vaccine rates in underserved populations. And that research is ongoing, and actually we've been having some success in partnering with organizations like the American College of Physicians and others to increase flu vaccine rates in practices. So we do quality improvement initiatives that go into practice and try to work with them to increase flu vaccination rates. And we think that this work that we're doing in flu vaccine is a predicate to what can happen when we have a vaccine for the virus. So we've created lots of tools that are available, and at the end of this presentation, you'll have my my email address, and we're happy to share those tools. This is work that we've undertaken to create these tools, both for patient activation as well as to help clinicians to increase vaccination rates in their practice. And we're happy to share with you, from press releases even to sermons, on how to increase vaccination rates. We have a whole initiative, it's called Drive. And again, we're doing infographics to explain to populations about not just COVID, not just about the vaccine, but COVID as well. We're happy to share these infographics with you, as well as other communication tools that might be available to you. So again, at the end of the my talk, you'll have my email address, and happy to share any and all of this with you. The other place we're taking a look is really looking at COVID by zip code. So a lot of our data is historic, meaning we're looking backwards and we're telling you what happened in the past. But we think what's really important, particularly for this pandemic, is to be able to start doing some predictive analytics down at the zip code level to be able to anticipate both cases of the virus as well as mortality. So we have a team that is working on this index that you see here. We hope to have it out by the end of November, in which we'll start to predict 60 days out what we think will happen in a zip code, both in terms of new cases as well as mortality rates. And the intent is by kind of giving the heads up, we hopefully communities will be able to use that information to lower the rates of cases and mortality in their communities. And this is, again, is another tool that we're happy to partner with. And if there are those out there who are interested in the collaboration, we're pulling together really a great team. And again, you can send me an email at the end of this talk, and I'll be happy. You can see, besides zip code, we're also making the data available by county, state, congressional district, and state legislative district as well. And here, this is actually some work that we've already started to do, looking at the mortality rates for COVID. This is looking at October's mortality rate for COVID across the country. And finally, as I said earlier, everyone understands that there's a disproportionate impact of the virus in minority and rural communities, but we don't understand the underlying science of what's driving that. So we've partnered with Centene, which is a managed Medicaid company, Quest Diagnostic, to put together the minority and rural coronavirus insight study. This study is looking at, it's a multi-sponsor study, obviously. It's prospective, longitudinal. And what we're doing is we are collecting 5,000 patients in the states of Illinois, Ohio, Michigan, Florida, and California. It's a 5-year study, including whole genome sequencing, doing a number of clinical essays, social determinants of health. And what we're trying to get our arms around is why are we seeing this disproportionate outcome in minority populations, and what can we do to lower those risks, particularly in future, potentially future pandemics. And again, with this study, we are collecting a lot of clinical assays, hemoglobin A1Cs, C-reactive protein, testing for the antibody. And we're just not looking at some of the clinical stuff, we're also testing some of the devices that we're using. When you think about, for example, the devices that are used to test for the antibody, the virus antibody, a lot of those tests were not conducted in minority populations. So we don't know if they're giving the same results across minority populations. And so part of the work we're doing is to test the very devices that we're using. We're also running a lot of ancillary studies. That antibody testing study I've talked a little bit about, but there's also the antibody quantity. The antibodies, they're different antibodies, and they vary by age and gender and race. They may have some bearing on how people respond to the virus. So we're looking to do antibody quantity tests. We're looking to look at diabetes and the virus because people think that there's some higher risk for the virus for those who have diabetes. Looking at cardiovascular disease, also looking at the virus in Hispanic populations. So all of that, including that study there, we're anxious to partner with. You can reach out to me at any time, and we'd love to partner with you around the flu vaccine, the coming COVID vaccine, the mapping of the virus, as well as the long-term study. So thank you so much.
Thank you, Gary. I think that the National Minority Quality Forums, their studies, the DRIVE initiative, they're doing some incredible work. So I hope our listeners do reach out to you and learn more if they're interested. Next, we will hear from Dr. Angela Riley. Dr. Riley currently serves as a clinical pharmacist. She is also Binghamton City Councilwoman, and Speaker of the House for the National Pharmaceutical Association. Dr. Riley's practice, service, and scholarship activities are closely intertwined with her areas of interest, so focusing on health promotion and education in underserved populations and older adults. Angela has developed several pharmacy graduate level professional practice courses that aim to equip students for success in their experiential and postgraduate experiences. Angela has obtained several grants and contracts, including a community action grant from the American Heart Association, and recently received the Stephen David Ross University and Community Projects Fund. Dr. Riley graduated from Texas Southern University College of Pharmacy and Health Sciences with her Bachelor of Science in Pharmacy and obtained her PharmD degree from Midwestern University Chicago College of Pharmacy. Angela serves on several national, regional, and local boards and committees within various organizations, including the National Pharmaceutical Association, Phi Lambda Sigma Leadership Society, the American Society of Consultant Pharmacists, and Delta Sigma Theta Sorority Incorporated. Dr. Riley, you're up.
Thank you so much, Veronica. I also want to thank Carl and Lacey, the entire NGA team, and the collaborators that developed this program and invited us to speak today. I am representing the National Pharmaceutical Association and really want to highlight the role of the pharmacist in promoting minority health amid the COVID-19 pandemic. Over the course of the next few minutes, I promise I'm going to stick to our designated time frame like Gary did. So thank you, Gary. I'm going to give you a bit of an overview on NPHA, the role of the pharmacist, what has happened with the pandemic effect, The intersection of systemic racism, health equity, clinical practice, and minority health, and what we foresee as the next steps. So, the National Pharmaceutical Association is a national professional organization of pharmacists founded by Dr. Chauncey Cooper in 1947. It was originally a subgroup of the National Medical Association. The organization was developed to focus on the needs of the minority community. Our goal is to promote excellence and uniformity among minority health professionals in order to improve the quality of healthcare in minority communities. Today, we continuously represent the views and ideas of minority pharmacists on critical issues affecting healthcare and pharmacy, with a goal to advance the standards of pharmaceutical care, direct patient care amongst all practitioners. We are a small but mighty organization, which includes our subgroup of student pharmacists dedicated to the same mission, with highlighting or really focusing on the profession of pharmacy, healthcare issues, and poor minority representation in all of these areas. The pharmacist is an essential member of the multidisciplinary team and on the forefront of healthcare, working on the front lines, not only assisting with adherence to medication, but the proper management of chronic diseases. The most frequent type of clinical pharmacist interventions are highlighted above, but we represent our change to the practice and the improvement of clinical care goals through the discontinuation of medication, continued laboratory monitoring, immunizations, and medication order modification. The most common reason for most drug discontinuation was seen with polypharmacy or multiple medications, where the pharmacist intervenes, makes recommendations. And this is a major concern, a major complication for both our older adult patients and our patient population with mental health conditions. In fairly recent data, it was estimated that with the number of clinical pharmacist interventions, we are able to impact an overall cost savings of over $63,000 per patient and a reduction in over $7,000 related to medication-related costs. So the pharmacist is essential to public health. Many of us provide direct patient care daily. We are one of the most accessible healthcare practitioners, with 90% of the country, again, being able to reach out to their pharmacists and living within 5 miles of a local pharmacy with a pharmacist. We are the key to immunization access and vaccination rates. As mentioned earlier, the flu is one of our direct correlates to addressing the COVID vaccine. And if we look at that data, we see in 2018, 2019, 1 in 3 adult influenza vaccines were provided by a pharmacist. In 2009, when we saw the H1N1 pandemic, the vaccine included a pharmacy initiative. When the CDC released 5.5 doses out to pharmacists, we were able to increase the vaccine administration by 5.5 million. The pharmacists are moving the needle and are ready to face the charge to impact public and population health. All right, a little technical difficulty, sorry about that. So COVID-19 is the ongoing global pandemic that has resulted in over 208,000 deaths to date, with higher contraction rates, as mentioned earlier, in the Black or African American and Hispanic Latinx populations at 2.6 to 2.8 times higher than the white population. Data from the CDC on COVID-19 infection and mortality rates have shown high incidences, again, as demonstrated earlier, in specific geographic regions. For example, we saw in Louisiana that the rates of hospitalization and death were higher in Black patients and twice as high as would be expected based upon the basis of demographic representation. Similarly, due to the service occupations, the greater representation of Black populations and minority populations in these roles, and the greater likelihood of living in inner cities with high population density, minority populations were faced with increased exposure to COVID-19 and greater risk. Again, COVID-19 did not begin the issues faced by systemic racism, but highlighted the problem. Amidst the protests, particularly in the United States, highlighting a history of marginalization and discrimination against Black Americans, 250 years of slavery, 100 years of Jim Crow laws, high rates of incarceration, and unanswered calls for action after police shooting of unarmed Black Americans. It was a problem across this country. The COVID-19 pandemic then allowed us to see a clear illustration of the intersection of structural racism, social risk factors, and health. For the Black healthcare practitioner, it is even more challenging because we stand at the intersection of systemic racism, health equity, our desire to provide a robust clinical practice focusing and highlighting on minority health. Not only do we recognize the prevalence of medical mistrust in our own communities, but our lived experience compound the historic failures in not only government response to disasters, but medical abuse, neglect, and exploitation. Many studies cite the Tuskegee study of unrelated syphilis in the Negro male as a main source for the mistrust in minority populations. However, we can also cite Henrietta Lacks and the continued concerns that result in a disproportionate maternal and infant deaths in Black communities. Equity is the goal. Health equity is the charge. As it stands, we see the consequences of health inequities and health disparities. Because inequities contribute to poor health in our US population, this leads to increased healthcare costs and consequences for our future generation, the overall US economy, national security, and our workforce and public finances. Poverty, food insecurity, lack of stable housing, and lack of access to quality and developmentally optimal early childhood education are amongst the childhood determinants that contribute to chronic adult illnesses and the perpetuation of poverty and ill health found in many communities. As mentioned before, this begins the cycle due to decreased access to quality care, increased healthcare costs, and economic impacts. This poor health status, unfortunately, also affects not only reporting to work, structural systems, but also entrance to military services, our national security forces. Data shows that more than 75% of the 17 to 24-year-olds, more than 26 million young adults who have typically qualified to serve are no longer able to serve because of their health concerns. As Black clinicians, we are faced with preventing illnesses and injuries before they occur. We can use this framework of prevention to also address and eradicate medical racism. NPA wants to use this framework, coupled with our dedication to public health, to lead the charge. So what are we doing? NPHA has created several activities to not only increase our public-facing provision of care, but to build relationships, to break silos, and create cross-sector partnerships. So we combined with other pharmacy organizations to create a joint statement on actions to address racial injustice, again, because if we highlight the systems that plague us, we are able to address and properly fix the systems. We've created and collaborated with other organizations such as NMA on the COVID task force, particularly the COVID-19 Commission on Vaccines and Therapeutics. We created a racial inequity series for healthcare practitioners, again, highlighting some of the issues that plague us. And we've continued to join other organizations and calls, for example, with the Assistant Secretary for Preparedness and Response, to remain informed and ready to move forward. Pharmacists, again, are anticipating their role in the allocation and distribution of the approved COVID-19 vaccine. As you heard, pharmacists are out on the forefront, offering additional access to COVID-19 testing, and will be prepared to assist with the vaccination. Over 1,300 pharmacies have received approval to provide point-of-care tests, including COVID-19. The U.S. Department of Health and Human Services authorized all state licensed pharmacists to administer vaccines for the COVID-19 once it is approved and available. The great thing is that we can include our students so that we can, again, extend access and provision of the services. So what do we define as our next steps? First, again, we must highlight the healing that needs to occur regarding the mistrust in the medical field. We must also continue to highlight and work collectively to prevent barriers to care. And we can do this by, one, changing policies that keep structural racism in place, continuing to break down silos and create cross-sector relationships, as I mentioned earlier, which would include not only recognizing pharmacists as contributors to the newly developed processes and policies, but recognizing pharmacists as providers so that they too can be equitably compensated for our services, such as the telehealth services, our COVID-19 vaccine administration and testing, and the ability to compound medications that have been on short supply due to some of the delays in delivery and access. We can prioritize diversity on any further task forces and working groups, for example, Operation Warp Speed. And this diversity would include diverse ethnicities as well as professions, as I mentioned earlier, include the pharmacists and other practitioners on these working groups to provide well-rounded information. We also collectively can advocate for transparency. The vaccine clinical trial process needs to be open and readily available to everyone, and it needs to be translated in lay language so that we are able to share this information with all populations. We also want to ensure that the trial populations include diverse populations and those ethnicities that have been disproportionately affected by the COVID virus overall. We want to highlight and implore the CDC, state and county departments of health to continue to provide their data and share all of the information found to their communities, particularly their communities of color. We want to implore everyone to support us in our advocacy efforts to increase funding, to support community educational outreach, to ensure that everyone is informed and aware and know how to obtain more information and access to the vaccine once it is available. Again, my name is Angela Riley. I'm a representative from the National Pharmaceutical Association. And if you have any questions, if you would like to partner with us on any of our advocacy issues, or you would like us to partner with you, please feel free to reach out. My email address is listed on the screen. Thank you so much.
Thank you, Dr. Riley. I really appreciated everything that you highlighted pertaining to the different role of clinicians, namely pharmacists, when addressing this public health crisis. And then the points of intersectionality that you were able to address as well, and how critical that is when discussing equity as we're working to combat the COVID-19 pandemic. So thank you so much. We will now hear from Andy Pickett. Mr. Pickett is the director of the Bureau of Public Health Preparedness at Pennsylvania Department of Health. He was appointed to the position in 2015, and his work as director of the Bureau of Emergency Preparedness and Response within the Department of Health works to oversee the implementation of the Public Health Emergency Preparedness and Hospital Preparedness Program as the federal cooperative agreements, and he manages public health and medical preparedness and response efforts across the Commonwealth. Prior to his tenure in his position currently, Mr. Pickett has worked in local public health emergency preparedness and county emergency management for over 10 years. Academically, he holds a Bachelor of Science degree in Geographic Information Science from Central Michigan University and a Master of Science degree in Public Safety and Emergency Management from Eastern Michigan University. He has also participated in the Executive Leaders Program through the Center for Homeland Defense and Security at the Naval Postgraduate School. Andy, I'll go ahead and kick it off to you. Thanks so much.
Great, thank you, Veronica, and thank you to the NGA team and for everyone who has made today possible. And I certainly want to thank our participants for joining us as well. I understand apparently my webcam is cutting in and out a little bit. I would unplug it and plug it back in, but I'm afraid I would blow up the whole Zoom meeting. So I'm going to not do that. But the content on the slides will hopefully make my point better than looking at me will. So I'm talking to you today about, we had two presentations on the broad strokes of ethics and healthcare and racial equity, specifically related to COVID-19. But now I'm going to take it to a point where sort of the rubber meets the road and what public health can do and has done in terms of implementing this, especially when it comes to scarce resources like medical countermeasures. So this is going to walk through the Pennsylvania Department of Health's journey when it came to the implementation of remdesivir in the Commonwealth. So to start off, we have to kind of take a step back and look at where we were coming from. In 2018 and 2019, our leadership went through a strategic planning process and actually really emphasized the complex ethical values in public health and especially in public health emergencies. So we knew that this was an imperative of our administration and our leadership to begin to develop a framework that would allow us to operate ethically during a disaster. And in 2019, we convened a steering committee to develop a crisis standards of care framework for healthcare partners. And our steering committee brought together healthcare, public health, legal, ethics, and we had started a path forward. We had taken best practices and guidance documents from federal partners, other states who had gone down this road before us, in order to develop a document. And we had intentions of working with a wide range of partners from across a number of different spectrums to provide input and feedback into that plan. However, something happened called COVID-19. And so we had a plan, and it was a decent plan. It wasn't a great plan, but the emergence of COVID-19 really changed the way the Department of Health had to operate. We were going from a theoretical exercise and planning for something in the future to planning something for now. And so we issued that crisis standard of care framework right at the beginning of the pandemic with the impending healthcare surge. Certainly we recognize that some jurisdictions had a massive healthcare surge and incredibly limited resources. Fortunately, in Pennsylvania, we were never that bad, but we needed to get the plan out the door and ready to go. And that plan sort of became the framework for the rest of this presentation to follow. So earlier this spring, the federal government announced that remdesivir was going to be distributed as a viable treatment option for COVID-19. And certainly we wanted to make sure that Pennsylvania residents who could benefit from this medical treatment would be able to do so. But of course, we had a lot of questions. When were we going to get it? How were we going to get it? Who has to manage it? Who's going to benefit the most from treatment with this product? So there were certainly a lot of questions, and if the last 9 months or 10 months have been any indication, typically any one answer will bring up at least 2 more questions that we have to combat. So when we were thinking about the development of this program, and based on the guidance we had received from our federal partners, we knew that there were 2 major issues that we were going to have to tackle in terms of our distribution. One is, how do you get it to those facilities? But then knowing that resources are going to be scarce, how do you get those facilities to provide it to the patients who need it most and can use it in an ethical framework? So those were the 2 major things we needed to combat. We knew that that first part on, how are we getting it to the facilities would be fairly easy. We knew that there was general guidance that was part of the emergency use authorization, that it was intended for hospitalized individuals. This isn't, something that we're going to give to everyone who is sick at home with COVID. This is really for the sickest of the sick individuals. And so we thought about, where are these individuals? Well, we know they're in hospitals. And fortunately, we have a robust system for collecting data from our hospitals about the number of patients that they are treating, and then to some degree, the severity of those patients, because they were reporting how many patients are currently on a ventilator. And so what we would do is we were receiving a weekly allocation from the federal government. And initially they were shipping it directly to us. That later shifted from the federal government shipping to the state health department, and the state shipping it out to the end user. It shifted halfway through where the federal government and the manufacturer would directly ship to the facilities, but it had to be allocated by the state health department. And so we developed an allocation formula based on the number of those positive individuals and the number of positive individuals who are on ventilators over the last 7 days. And that gave us sort of an indication of which hospitals were treating the most patients and who would need it. Certainly not all facilities receive the product because, again, resources are scarce, and we had over 2,700 individuals who were hospitalized at the peak in April. And unfortunately, our numbers are going up again. And certainly we had to, come up with some minimums. For example, a box of remdesivir is 40 vials. We didn't want to have to break boxes open and ship individual vials to facilities, especially since a course of treatment is either 6 or 11 vials. But that micro level, patient level distribution was much harder. Again, we had multiple residents, many hospitalized, and certainly we weren't receiving 3,000 courses of medication each week. So we knew that we needed that ethical allocation framework. And fortunately, we had that crisis standards of care plan that could begin our path forward for us. We created an ad hoc committee, and really we were able to leverage some of the folks that we had really wanted to engage in developing that initial plan. We brought together state agencies who have been highly engaged in our COVID-19 response, our Department of Health, our Department of Human Services, our Emergency Management Agency, but we also brought in external partners, healthcare partners, health ethics, health law, because we wanted those diverse backgrounds and those diverse opinions to help us create this framework to be the best it could be. So we held multiple conference calls over a couple-week period. We discussed several potential options. And really what we came to was, what were healthcare facilities currently doing in terms of ethical allocation? And ultimately, we stole one facility's plan, and then we took the input of all of our other partners and we made it better. In our emergency preparedness world, we're not afraid to do a little R&D, which is rip off and duplicate. So we want to, take the good work that's already out there and leverage it the best we can. And we knew that whatever plan we came up with had to meet certain goals. It had to be guidance that the facilities can follow and be relatively easy to follow, maximize the benefit while ensuring health equity, and fall in line with our current federal guidance and direction. And so this is an excerpt of the document that was created by our team. We knew that we couldn't go with certain things. We couldn't do a completely randomized lottery or a first come, first serve, because they don't satisfy the ethical goals outlined, and they don't proactively mitigate the health disparities in COVID-19 outcomes. So we needed something that was going to be better than those easy answers. So what we ultimately hit upon and came to consensus on was a weighted lottery formula. So there is some level of chance where everyone has some opportunity to receive the product. And so it's based on this idea, and this is sort of an example here. If we know we're going to have 3 courses available, and we anticipate having 10 patients come in this week, each individual starts with that 30% chance of receiving the medication, because that's 3 out of 10. But then that metric gets adjusted up and down based on some key factors. And we decided to promote the priority of individuals from disadvantaged areas. And I'll talk about that a little bit later with the Area Deprivation Index score. But we felt that that was a good way to look at the social determinants of health and the existing health disparities that are inherent in COVID-19, and use this as a mathematical formula, mathematical number that can be plugged in. And we also looked at essential workers. Now, this was actually something that was very contentious, because even some members of our own leadership were hesitant to give priority to essential workers. It's felt too much like we were looking after our own, but not the community at large. But certainly there is an aspect of those healthcare workers are essential to making sure we can prepare and respond to this pandemic moving forward. So ultimately they were put in as one of the elements to promote the score. And then lowered priorities for individuals with an end stage condition, which we defined as less than 1 year of life expectancy expected at that point. So then we put it all together and we published it on our website, and we pushed it out through the various healthcare associations and the different advocacy groups in order to educate and inform our healthcare sector about this plan. And I'm going to just bring up some screenshots that walk through the plan. And I know I don't have a whole lot of time, but I do want to share what this would look like in a clinical setting. So anytime that the facility needed to allocate, they needed to, again, look at the number of patients that they expected to have to treat compared to the number of available courses. And again, those two factors set the baseline, and determining what the general population patient, what theirs would be. And so in this particular example on the website, if there are 25 courses of drug available and 100 patients expected to be eligible over that time period, the next week, the next month, et cetera, then the general population chances are 25 out of 100, or 25%. And certainly this is something that, because patients are coming in and being discharged every single day, the hospitals have to sort of play the long game and look at what they are expecting over the next period of time. And certainly, making sure that they are eligible. The FDA emergency use authorization had certain requirements that had to be met for individuals. I don't believe it was authorized for children. Don't quote me on that, but certainly we wanted to make sure that those receiving it were eligible. But then we got into the sort of, what is the math? And we had to establish whether the patients fit into these groups. So if they were coming from an area with that area disadvantage index score of 8 or higher, they would be 1.25% times that general community chance. If they were an essential worker, it'd be 1.25 times death likely within year, 0.5 times. And then certainly if you had multiple factors, if you fit into multiple groups, that would change your score as well. So again, are they from a disadvantaged community? Are they an essential worker? Are they in a chronic end stage condition? And then there had to be some math. So, again, if your baseline score is 0.25 or 25%, but you come from an area deprivation index with a score of 8, 9, or 10, it was 1.25 times that 0.25, which led to a higher score. You now had a 31% chance of receiving the medication. And then really at this point, it's just, not to be too crass about it, but the act of rolling the dice. And several healthcare systems actually just, Google has a random number generator where it will randomly return a number from 1 to 100. And for each patient coming in, they would do the math for that patient, roll that number, and determine whether or not they were eligible for treatment with remdesivir. And one of the key things is it's unfortunately, because we have the number of patients coming in on a routine basis, they have seen one opportunity upon a time that the attending physician feels that remdesivir is necessary to be entered into their healthcare systems program. And then certainly you need to have that conversation with the patient's family, and certainly if they are to receive treatment, being able to do that as expeditiously as possible and making sure that this process has been documented. Now, I talked about the area deprivation index, and I am a GIS nerd, and so looking at how we can get some data to help, we used the Wisconsin School of Medicine and Public Health's Neighborhood Atlas, which has a area deprivation index, and it's really an aggregation of a number of different social determinant of health factors. And then it is presented in a way that gives every census block a score. This is just the information directly from the website. It allows for, really just looking at where those communities are, where there is where those factors are in play that we know an individual coming from that community is likely to have more negative health outcomes. And so this is just an example of what Pennsylvania looks like on that system. As you can see, each census block is rated from a 1 to a 10, a 1 being the least disadvantaged and a 10 being the most disadvantaged. And so I know it's kind of arbitrary, but our team came up with an 8 or higher. So an 8, 9, or 10 would be given that preference in the weighted lottery. And so, for example, if you type someone's address in, and this is the address of our office here in Harrisburg, you can see that our score was a 3. So if I registered and I needed remdesivir at this address, I would not have been eligible for that additional weighting. But there are some census blocks in the immediate area that certainly would have been. So how did this all work for us? Certainly it was easy to implement across the healthcare systems. And we certainly wanted to ensure, or we certainly recommended this to facilities because we wanted there to be a uniform framework across healthcare, across the state. And it certainly met all of the requirements we had for ourselves in our crisis standards of care and practices of health equity. The cons, it required data to implement, knowing how much product, how much medication you're likely to see, how many patients you're likely to see. There is some of that, those unknowns that can make it a little bit more difficult. And where do we go from here? We're actually talking about how do we do COVID-19 vaccine planning in a way that will also be ethical in how we allocate product. And so we've discussed the weighted formula model. I think this becomes a little bit more difficult to implement because of those data requirements, and certainly we don't have as many folks in a hospital setting where you can't roll the dice for everyone who's standing in line for a vaccine. But we've also looked at targeted distribution on that sort of macro level and looking at that ADI score, and can we identify healthcare providers who are in those higher area deprivation index scores to target them for an earlier allocation of the vaccine. And certainly we want to improve our crisis standards of care framework. Like I said, we went from not having a plan to having to push out a plan to our healthcare partners in a very short amount of time. And we would have appreciated an opportunity to have a lot more dialogue with other partners and have more insight and opinions into our plan. So we certainly want to go back to that drawing board and make sure that we can have that community engagement to make the plan the best that it can be. So there is my contact information, and I believe, Veronica, we can now open it up, I believe, for questions and answers. So I will turn it back over to you.
Thank you so much, Andy. I think that's a new framework to look at this through, and that figuring out that we have to have each individual state reckon with and need to establish their own ethical values when responding to these, quick crises. So very critical piece there. Thank you so much. We do have a couple different questions coming in on our Q&A section of Zoom, and I've also received a couple personal questions. So I wanted to go ahead and start off with the first question I received, and that is for Gary. And Gary, really a big question is, is there anything that governors should be doing and their staff to become more involved with some of the work that your organization has been doing, or have you all been engaging governors at the state level, or what could that partnership look like?
So I think one of the big issues that I think would be helpful to everyone is being able to bring the data together so we can see where the COVID risk exists, not just in the past, but putting some predictive analytics together so that we can intervene early in hotspots and doing the necessary follow-up. I know each state is probably doing it on their own for their state, but the virus doesn't know state borders. And it's really important to bring the data together in one place. So what we have now is we have national estimates about what's going on, the mortality rates and the number of cases at the national level, and certainly we're capturing the data in terms of historic data at the county level. All of those are good and important, but they're not really actionable. And what we need is actionable information. And so, we've been putting together a GIS system that will allow each individual state to take their data and pull it into the system. They can add overlays and other things to it. We think that that's really important. And then the other place I have to mention is really the flu vaccine. We see that the flu vaccine, at least certainly in minority populations, is not being well administered, and a collaboration to make sure that everyone is getting the flu vaccine, particularly those underserved communities, because it's a prelude to what needs to happen with COVID. And I think that's a place where we can get a lot of learning together on administering the flu vaccine. And the flu season is now, so it's really important that we get going now.
Great. Thank you, Gary. I think that we also had an additional question regarding some information on flu communications and those materials. So for those of you that are interested, Gary did provide the email to an individual over at NMQF that anybody that needs those materials can reach out to. That's in the Q&A section. I will also go ahead and post it in the chat section so that everybody can get that email. But so the next question that we have, and sorry, y'all, we're going to jump around a little bit. The next question is going to be for Andy. So we received a question from Suzanne Curtis asking, is Pennsylvania Department of Health looking to put together a similar framework for the allocation of the COVID-19 vaccine?
Yes, we certainly want to make sure that, especially early in the system when, or early in the process when the resources are limited, we're going to need to find a way to ethically make sure that we're getting it to the right segments of the population at the right time. And there's certainly some federal guidance on the prioritization of certain populations, but then within that broader federal guidance, how do we target things within the context of this ethical framework? So it might not look like a weighted formula or a weighted lottery, but we are working to ensure that we can do this the right way.
Great. Great. And another question while we have you on, Andy, is can you answer what pushback, if any pushback, that you have received from Pennsylvania's ethical framework outline?
So, no decisions that are made ever make everyone happy. When you have scarce resources, it's impossible to give everyone what they want. And in many cases, it's impossible to give everyone what they need. And certainly we have had some constituent groups that feel they are being not addressed or having their needs addressed appropriately through both our crisis standards of care framework. And, there was a particular online news outlet that did a story on our ethical allocation framework for remdesivir that, got some attention. But from a public health standpoint, we felt that we were doing the right thing, and we weren't going to let that kind of communication really hinder our efforts.
Great. Great, thank you. So we'll go over to another question that we've received from Angela. Also, for anybody interested in any additional conversations, we do have a couple different questions going back and forth and being answered in the chat box. So Angela, you talked a little bit about some of the hardships that different clinicians, specifically clinicians of color, may be facing when trying to combat the COVID-19 pandemic for themselves as well as for their patients. So can you tell me a little bit more about, what states and governors could do to make sure that not only are their clinicians represented and they're receiving the resources they need, but also making sure that those clinicians are able to serve their patients?
Yes, that's a great question, Veronica. As I mentioned in the presentation, it's important to make sure those voices are represented at the table. So including diverse representatives, that means all types of clinicians, the pharmacists, the physicians, when making those decisions regarding the vaccine dissemination, even the treatment protocols that are developed once we know how this virus is going to be addressed. So it's important that our legislators, our governors, again, listen to all the voices around the room, particularly the voices of those that have been disproportionately affected by the virus overall. And yes, that would include not only inviting those representatives to become a process of in the development and some of the treatment and dissemination protocols and practices, but providing resources to the communities to address and educate and advocate some of the strategies that are developed in those working groups and on those panels. The community outreach is essential to not only engaging populations that have been disproportionately affected historically, but also providing a source of healing, as I mentioned, also that we want to prioritize the needs of the community and again, reduce some of the tragedies that have happened in the past.
Thank you so much, Dr. Riley. And so we have one other question for Gary as well. So going back over to the National Minority Quality Forum, Are there any key learnings that you all over at NMQF have acquired from the pandemic that you may have been surprised about, or something that you all did not know that you would be researching and doing data on as we are currently?
Well, I think like all Americans, we were all caught off guard by the virus for sure. Certainly caught off guard by the disproportionate impact that was having on minority and rural communities. And I guess the most important takeaway for us, the lesson that we learned, is that we have to pay a lot of attention to patient risk in our healthcare system. And what I mean by that, there's a tendency in our healthcare system to pay more attention to financial risk. And there are lots of reasons for that. But the problem is when we pay more attention to financial risk and patient risk, what ends up happening is that we end up with a tiered healthcare system with all kinds of inequalities. And that's in effect what's happened with COVID. And I could go into a long philosophical reason that goes to the founding of our society, why we pay attention to patient risk, and right into the Declaration of Independence. But the point is, and the lesson is, that we really have to walk away from this. Healthcare is a deep collaboration. We all have to work together to make sure that we can conserve high quality lives. That is the point of the healthcare system. It is not about elevating anybody's risk. It is about lowering risk, period. And if we get confused about that, we're going to end up with lots of people who get sacrificed, bluntly speaking. And so, that's our takeaway, and hopefully the takeaway for all Americans when they look back on this pandemic and the history is told. That is, there's no short answer to that. That is the answer that we have to walk away with.
Thank you, Gary. Our next question comes from Patricia Cummins, and she wants to hear from Andy. How are you engaging with local governments, healthcare providers, and pharmaceutical manufacturers in developing the vaccine and the distribution planning? Are you taking advantage of your GIS for sharing data and evolving a plan, or anything that you'd like to go into there?
Yep. So what we have started with at the direction of our health department leadership is, again, convening a committee to provide that strategic level guidance and making sure we're adhering to our ethical standards as a department. So we do have representation of healthcare facilities, both acute care and primary care. We have representation of the pharmacy community, both retail pharmacy and inpatient pharmacy. So we have a wide range of stakeholders. I don't believe we have any representation from local government on that committee, but that is what we have done to sort of frame out our planning at that level. In terms of utilizing GIS to make decisions or to share information, we have not currently implemented any geographic data into that planning process yet. But I think as we get down to more and more granular, more operational aspects of our planning, we will certainly have an opportunity both to use our GIS tools that we have available to us to inform our decision making, as well as provide information to the public. So that is certainly something we will be moving forward on.
And just to stay with you, Andy, can you tell us, did Pennsylvania, the Commonwealth, do any sort of evaluation to determine how effective the ethical framework is, or how it was delivered at the patient level?
Yeah, we haven't done any deep statistical analysis of it yet, and I'm certainly not an epidemiologist, and looking at that many numbers makes my head hurt. But we have data on the number of individuals in racial and ethnic groups and age groups across the Commonwealth who have been hospitalized. We have that same data on those who received remdesivir. And we were able to look at those data sets side by side. And I don't know if it is statistically significant, but it was certainly not discouraging to say that any one community across the state, whether that's a geographic community, a racial or ethnic community, an age graphic, demographic, was monopolizing the remdesivir allocation. So it seemed to be an equitable distribution across the Commonwealth. And I'm hoping that when we have a little bit more time to take a step back from the fast pace of the operational role and look at it in a retrospective way, to be able to really dive deep into those numbers and determine, did we really meet our mark, and did we really ensure that we were lifting up disadvantaged communities across the Commonwealth and making sure that they had the resources, including the scarce medical countermeasures that were available.
Great. Great, thank you, Andy. So the next question then, our final question, everybody is more than welcome to continue to add their thoughts and questions in our Q&A section. But otherwise, I wanted to go back to you, Dr. Riley, to give us your 2 cents as far as states and governors' involvement in the COVID-19 response. Do you feel that there has been any specific Department of Health that has really worked to hit on those transparency concerns that you've mentioned, or anybody that we think we could learn from at the state level?
That's a really good question. I think, as mentioned earlier, we know we were all scrambling for information and really trying to develop a safe, sound plan to effectively minimize the spread while treating those that have been infected. I will say there were several organizations leading the charge. I'm extremely proud of my own governor, Andrew Cuomo, for the updates and the inclusive practices here in the state of New York. In terms of modeling, however, we're finding out daily practices that were inclusive, transparent, and included some of the strategies I mentioned in my presentation regarding having various practitioners at the table, as well as including diverse populations in the rollout of some of the trial protocols for treatment of COVID. So I don't want to necessarily quote or highlight any one particular group, but I encourage all practitioners, all governmental agencies to share the information they've done, even if it was one case study that was relevant and we saw success or inclusive practices, so that we can highlight those models and then they can be replicated across the country. That's how we change, again, what has happened, and we move forward as a country by sharing what works, being inclusive and transparent. And I encourage everyone to share their models of care, as Andrew has shared from Pennsylvania today.
Thank you, Dr. Riley. So we did get another question in our Q&A box from Beth Armentano. It's a question for Andy. It sounds like it was an equal distribution of resources, but was equality your goal over at the Department of Public Health, or were you all looking for an equitable distribution plan?
I'm not the health ethicist who is part of our team, and so we have a health equity framework. And so I apologized if I mangled my messaging earlier, but we wanted to make sure that our distribution was in line with the health equity framework. And based on the data that we have, it appears that that was the case. And I could bring in some other folks from our team who could speak to that much more eloquently than I can. but that's what I'll say to that right now.
Great. Thank you. So again, any additional questions? I think our panelists have been very generous with their time, and they have also offered their email addresses in these slides for you all. So please feel free to reach out to them with any specific questions. You may also reach me should you have any questions just about this great moderating session. But Gary, Angela, Andy, thank you so much for giving us your valuable time and sharing your expertise. If anyone has any general questions or would like to follow up with the speakers, please feel free to contact them. And you can also contact Claudia Bonilla. Again, it's cbonilla@nga.org. To continue this conversation, equity and policy preparedness during public health emergencies, you can join NGA for their next upcoming webinar in this series. The next webinar will focus on people experiencing homelessness during this battle against COVID-19. The registration link for these webinars will be sent out following today's webinar, and we look forward to your participation in future webinars. Thank you again, and to our speakers and audience for their participation, and enjoy the rest of your day.
Thank you.